Hello, everyone. Can we verify to see if you folks can hear me, please? And one other confirmation, I'm loading up the presentation. I want to make sure, is there any lag into this? Great. All right. So thank you for, we've been absent for a little while, sort of reorganizing and coordinating a few things. We'd suggested that it'd been suggested that we can do a question and answer session. I'm sure you can see that there's a chat box. You can enter your information. Also, my camera is in front of me with a screen monitor, and there's a secondary screen monitor on to my right, to my left. So when I'm looking at it, I'm not looking away. I just have to look at the slides and back and forth. So. The two questions that I would like to address is that, please make sure that you are signed up on our website to get updated information on our blog. We're going to be writing a blog, or it's going to be published about follow-ups and follow-up structures. That's very important. The other thing that I want to talk about is that we've repetitively said calcium and parathyroid hormone and vitamin D. Saw a patient earlier last week, actually. Hadn't seen her for a long period of time. She brings a set of blood work that she was given, and then the secondary, vitamin D and other stuff comes as a later date. So on her record, it showed as incomplete. So we're going through the list, and it shows that her calcium is normal. Her now alkaline phosphatase was mildly elevated, and the ones that I had received show that the delayed labs were all updated, and those included things like the vitamin D and PTH level. So she has a copy of the lab results that has a normal calcium level. I have a copy of the same labs with complete results of normal calcium, very low vitamin D, and sky-high PTH. And the discussion that we got into was to remind ourselves that a normal calcium level is essentially meaningless unless you have a concurrent PTH, alkaline phosphatase, bone scan, vitamin D, all of them above or some of them together. Because a patient could potentially maintain a normal calcium level during a time frame when their bone is being broken down by elevated PTH level, which is a normal response in order to normalize the calcium level. So we get an artificially normal calcium level at the expense of the bone breakdown. So that was sort of one note. The other thing that we've talked about in the past, again, is just to remind ourselves is there's three primary reasons why we recommend patients not to consume any alcohol. One of them is alcohol is free calories. It essentially defeats the purpose of any procedure, malabsorptive or not, because any alcohol can get absorbed very easily through any mucous membranes. The second reason is that alcohol itself is a stressor to the liver. So during a rapid weight loss phase, when my liver is stressed, I am furthermore stressing my liver by adding alcohol, which the body has to process. Last but not least is the fact that alcohol actually intoxicates patients at a lower dose after weight loss surgery than before. And unfortunately, we've become aware of patients who have had problem with may have been inconsequential before weight loss surgery, but rendered them to be incapacitated, not to be able to drive, and result in a DUI and things like that. So be mindful of that. So with that said, I would like to move and now talk about can you folks see my slides? And hopefully it's legible. So we're going to talk about dental health and weight loss surgery. I know it sounds like an interesting subject, but let's just dive into it and it'll become clear what the issues are. So some of this may be repetitive for everyone. Obesity is not a disease of overeating and lack of exercise. There's genetics, hormonal, environmental variables that plays a role into this. The notion that just eat right and exercise, everything would be fine makes no sense. This is sort of for dentists and all as healthcare provider, we need to really appreciate not to blame the patients for weight loss, for outcome of the surgeries, and look at in majority of cases, patients' outcomes are dictated by the procedure itself and not the patient's contribution or not. The information that we have right now really dates back in 2003. There's a study in Science magazine in February 7 of 2003 that for the first time actually was able to correlate the relationship between leptin and essentially demystifies this concept of energy and energy in and energy out. The drawing on the right-hand side, or on the slide's left-hand side, shows. Can you folks read this? Maybe I can. Let me do it this way, actually. Essentially says that in an energy state, in an energy balance, what everyone has always suggested, energy in and energy out, you have a stable weight. The problem is that you can actually be overweight even when your energy in is equal to energy out when you have a high leptin state. This is where we've, those of you that are saying you can't read this, I'll put some of these images on the blog so it'd be easier legible. Sorry about that. So what this demonstrates is that though is you can have in a state of energy in and energy out state where the amount of calorie, at least conceptually what I'm consuming equals to the amount of energy that I'm spending, and I'm still overweight. And I know to a lot of patients this is no earth-shattering science, but unfortunately to the ignorant old concept thought process that we assumed that everything should be energy in and energy out. This was cutting-edge science to demonstrate that leptin probably is more important in dictating the patient's, or at least this was an animal model actually. The animals models obesity state secondary to their energy in and energy out. So with a low leptin level, you have a normal weight, stable weight animal. In this case, it was mice. And in a high leptin level, you have an obese state, even though in both cases, energy in and energy out. If you have a decreased leptin level, then you may end up, and you have an energy out higher than energy in, then you will sort of lose the weight if your energy output, meaning the activity, is favored versus energy in is higher. So energy in and energy out, again, is only secondary to the leptin. Then we sort of take that and we look at the weight loss outcomes. There's sort of the good news and bad news thing that in a majority of the cases, the benefits of the weight loss surgery are better than their complication rate. There is, however, significant variability in the complication profile of the procedures. And this sort of pushes us to the next level of questioning is that though, should we not tailor the procedures individually per patient and then be able to tailor a procedure for a patient who will benefit the most individually for the safety profile of that procedure versus the complication of that procedure? So when it comes to the dental health, here's how, for those of you that are still wondering, why are we talking about dental health is, I can't see a show of hands for technical reasons, but I wonder how many of us have had issues after weight loss surgery, and more so in revision patients, more so in lap band patients, more so in gastric bypass patients that have had very tight strictures, that we started out with what sounded like a benign cavity. We have significant nausea and vomiting. We eventually make it to the dentist. The cavity is fixed. A few months later, it's worse again. We go back, and someone says, well, your teeth are falling apart, and we're going to have to do a root canal. And next thing you know, I'm a 40-year-old male or a female, had weight loss surgery, lost the amount of weight, and they're talking about having to do multiple bridges or maybe even pull everything out and do implants on everyone, on every position of the teeth. So the issues with the contributing factor to the health may be metabolic or local. Metabolic issue is what we're all aware of. Things like vitamin D and calcium deficiency. This can lead into osteoporosis or alveolar bone disease, essentially teeth being one of the most intense concentrated source of calcium, result in significant bone loss. Periodontal issues, this is the gum, the diseases related to the gum, and we'll talk about this. That shows you may be dependent into things like what we're consuming because of our diet, if we're having nausea or vomiting, and or vitamin D and calcium deficiency, in addition to local infection of the gum. Xerostomia, which is dry mouth, and because we're not soaking our teeth and mucosa, keeping them wet, dehydration and medication may result in periodontal disease and causing cavities. Dental wear and tear, dental caries, reflux, vomiting, and poor diet, as I said, an inflammatory state. It's interesting because at this, that is cellular and molecular level, high fat content in an overweight patient causes a higher inflammatory state. The IL-6 and tissue necrosis factor are at higher elevated level. And this is why, for example, things like psoriasis is more commonly improved significantly after weight loss surgery, because the inflammatory markers diminish and they go down. Some of these conditions that are outlined that may contribute to dental health or poor dental health are not related to the weight loss surgeries, but we're going to talk about them in that aspect. For those of you that are wondering, and have asked me every so often, I just got asked this last week too again, so I put the slide in. I do tie my own bow ties. They're not clip-ons. So moving on, let's talk about normal anatomy. You've seen, most of you may have seen this slide. In a normal anatomy, the GI tract allows the food to go down the esophagus, sits in the stomach, the valve opens up, the pyloric valve, and the food travels down the entire length of the small bowel. For all purposes, the discussion of the dental health, the acid-base mixture that takes place normally in the stomach and that ghrelin regulated to the brain, it's modulated by a number of variables, the acid, intrinsic factor, and so forth that are secreted with the stomach. As the food travels past the pyloric valve, they're neutralized with the bicarb and that secretions of the pyloric of the pancreas and the mucosa of the duodenum. So there's a natural normalization of the pH once the food travels down the pyloric valve. Anything that disturbs this pathway, either because of chemical imbalances, because of physiologic changes, and or because of the anatomical variation, such as there's a stricture that allows me, or I have an ulcer that causes frequent vomiting, will allow some acidic high content secretions to come up the esophagus, which may cause the reflux, esophageal erosions, ulcerations, and eventually injury to the teeth. So an example of that procedure may be the adjustable gastric banding, which causes a narrowed stricture at the very high level of the stomach. There may be some acid secretion, and continuously thrown up will result in exposing the oral mucosa, the teeth, enamel to high acidic content, and that will result in much faster wear and tear of the teeth. With the sleeve gastrectomy, with the 75% of the stomach removed, if patients have any stricture, if they have any narrowing of the stomach in a form of, for example, an hourglass stomach, that will result in the patient having persistent nausea and vomiting, and then the acidic content of the stomach will be expelled through the stomach, through the esophagus into the stomach, resulting in patients having wear and tear. Going down gastric bypass, similar story. Unfortunately, with the gastric bypass, though, unlike the sleeve and normal anatomy, there's a desire to make that opening between the stomach and the small bowel narrow on purpose. That's to limit how much food goes down. And because of that, you have a stagnation of the food that sits in the pouch. And if one extra 2 bites, the food will go up, expelled through the esophagus. A second reason why patients have frequent nausea and vomiting may be dumping syndrome. And dumping syndrome is the unopposed traveling of the food from the stomach into the small bowel, causes a rise in insulin and hypoglycemic episodes, and that results in a cascade of reactions, one of which may be nausea and vomiting. That results in, again, expelling the food down the up the esophagus, and vomiting, and the wear and tear of the stomach. Duodenal switch operation, most of you may be aware of this. It's a combination of the sleeve and rerouting of the small bowel. The causes of nausea and vomiting after duodenal switch operation are very similar to that of the sleeve gastrectomy, because the shape of the stomach is the same. The only variable here is that in addition to that, patients may actually have selective vitamin D and calcium deficiency, vitamin K deficiency, which is needed for bone metabolism, some of the minerals, which compounds any anatomical problems with the nausea and vomiting by causing nutritional deficiencies on top of that. It is important to appreciate that none of these things happen overnight. A patient that throws up once or twice after weight loss surgery is once or twice too often. And even with that said, will still have potentially very little effect if it's a self-limiting process. All of these problems that we're talking about, long-term sequelae of the poor dental hygiene, bone loss, alveolar loss, gum disease, are all related into chronic nature of uncorrected problem. And our point is that we should all, as patients and hopefully dentists, should be in tune that we should not look at recurrent, repetitive problems with our teeth or oral hygiene to be limited to that. We need to think about what else could be contributing to this. And as a DS patient, if I do not have any nausea or vomiting and I'm eating and tolerating everything, maybe we should raise this to our surgeon's attention, that can we look at our calcium? Let's look at our PTH. Let's look at our vitamin D. Maybe even though my calcium is normal, I really haven't checked my PTH and vitamin D level, and that's why I'm having so much problem with my teeth and my bone structure. I don't know how many of you have looked into this, but there's a just recently, a few months ago, the second gastric balloon was approved. I only have the image of the very first one that was approved. The gastric balloon is essentially a temporizing procedure that endoscopically the balloon is placed into the stomach, and then the balloon is filled with water. This is supposed to only be in place for 6 months. FDA and the manufacturer mandates that this is removed in 6 months' time. During that 6 month time frame, a patient is supposed to relearn better, healthier diet and activity level, better dietary choices, and it's supposed to, the presence of this balloon in the stomach is supposed to limit how much food patient is consuming. The second balloon that has come up, instead of being one large balloon that you can put in 400 to 500 cc's of fluid, there are two smaller balloons like a figure of 8. and it's supposed to mitigate and reduce some of the complication that some patients have seen with this. I'm not quite sure if I'm advocating this. The indication for this are that those patients that are relatively low BMI, 30 to 40, and they really should have no comorbidities. These patients should not have any reflux, and in fact, any diabetes or things like that are not really resolved with this. It requires a relatively high level of maintenance, meaning that the patients, these balloons are even less than the band, where patients had this assumption that I can just get the lap band in and go once in a while, get it adjusted, and everything would be happy ever after. The balloon is even less than that. The balloon requires even more maintenance, more follow-up. There has to be really a structured, complete dietary modification, and much more vigilance on the patients of overemphasizing, magnifying the effect of the diet and exercise. It is not permanent. After 6 months, they need to come out, and there's some preliminary evidence, there's some preliminary studies that are pointing into some groups and physicians and manufacturers that are saying, well, you can take this out and put one in. So before patients start calling our office, you should be aware that almost no insurance company pays for this, which is for obvious reason that this is only a temporary solution. It's not permanent and needs to come out every 8 months. So when you look at the benefits and the downsides to this, and I apologize, you can't see this very well on this. I'll put this information on the blog and you'll be able to look at it better. But 80 or 90% of the patients in the FDA mandated study had significant nausea and vomiting, even though this thing resolved over some time frame. There's a whole bunch of issues, things like dyspepsia and gastroesophageal reflux disease, in fact, continue to persist over a long period of time with this patient, which is why, as I said earlier, patients that have reflux disease should probably not have this band placed. Then when you go back, we look at two other variables, excess weight loss and the resolution of the comorbidities. This is sort of the easy one. If you look at, type 2 diabetes, hypertension, and lipid disorder, the Obera, which is the name of the band, the name of the balloon itself, and the control study had nearly identical resolution, which means that at 6 months, 9 months, out 12 months, there was no statistically significant difference to say that this balloon does anything for patients that have lipid disorder, have hypertension, or they have diabetes. Now, there's some groups and some secondary publication that will challenge this question, and they'll say, well, diabetes will get resolved, or type 2 diabetes does improve from a safety profile. But I think it makes no sense then to look at the weight loss data to appreciate why there's not really a statistically significant improvement in the profile or resolution of the diabetes, hypertension, lipid disorder. If you look at the amount of excess weight loss at 6 months, 9 months, at 12 months, and the weight loss group versus the control, no matter what type of measure you look at, even though there's real weight loss, the numbers are not really dramatic. So if you look at excess weight loss based on a BMI of 25, percent excess weight loss with the guideline, instead of being BMI of 25, we use MetLife data. Excess total body weight loss versus actual weight loss with all of those variables. So the top lines are the balloon, and the second lines in each group is the control. You'll see, for example, that early on, the amount of weight loss was 38 pounds. With the diet and exercise alone was 12 pounds. When you get further out, in about 12 months, this has maintained 30 pounds. This has only maintained 11 pounds if you use the percent excess body weight loss. When you do things like weight loss, 16 pounds of weight loss versus 7 pounds, 6 pounds of weight loss. So even though there's actual number, and these are statistically significant, one has to really question the notion that at 6 months' time, I have to take this balloon out, and I really have to stick this diet and exercise plan, which hasn't not worked for me before, in order to maintain that 5 or 10 pounds weight loss that's maintained. When you look at total body weight loss, it's even less, and the amount is somewhere in between when you're looking at the percent excess weight loss, with the guideline of the midlife as being the standard. So what the first time, and as I said, I'll put all of these things on the blog so it'll be easier to look at the data. What this essentially says is that, though, depending on what matrices you use, there's definitely weight loss. The weight loss does not translate necessarily into resolution of the comorbidities. And going back to the previous slide, there are some fairly dramatic complications that a patient has to consider. So I'm going to go back again to where I started with this, saying that I'm not necessarily saying that I'm in favor or I'm not. I think there may be a subset of patients that will benefit from the balloon. This may be a patient that does not have comorbidities, for example, who has 40, 50 pounds to lose, and they really have, for example, bad knees and bad back, for example, and they, by losing 20, 30 pounds, all of their problems go away. So this may be something for them to consider. A young lady who had 2 or 3 pregnancies, they've only got 40 pounds of weight to lose, and no matter what they try, it doesn't work. This may be something they can use, with the understanding that it's not a permanent solution. It'll just buy time, essentially. So I'll skip through the slides that is on our website and the complication chart. One thing that I want to show is, and this is on our blog, and it still makes me cringe every time I look at, a weight loss surgical options do go out there. This is actually a published data in a reconstructive cosmetic journal, where this surgeon is sewing non-absorbable Marlex mesh with non-absorbable sutures on a patient's tongue. And every time the patient tries to eat or chew or drink something, it causes a lot of pain. And the notion was that the patients lose weight because they can't eat and drink. I just want to say no comment on this. I'm not sure even if this may be crossing some ethical lines, as it may be, but this makes no sense, no long-term outcome. So this does not constitute, in my mind, a weight loss surgical procedure. Dry mouth can be caused by medications, antidepressant, anti-anxiety, antihistamine for things like Benadryl for sleeping, bronchodilators, and diuretics. Medications and medical conditions that may cause xerostomia, the dry mouth, maybe sleep apnea for patients that have sleep apnea, CPAP, especially the higher pressure that they don't. Some of them may or may not have some bells and whistles that minimize this, but in general, that's a problem. Diabetes, obesity itself, and patients have taught me on this that as overweight patients, I may not really want to go to the bathroom frequently, and so I will just avoid. I would avoid doing the drinking enough water to keep myself hydrated, so that now I'm dehydrated all the time. Epilepsy can cause that, rheumatoid arthritis, Parkinsonism, and clinically dehydration. If I just don't drink enough water, I'll have that problem. Common issues nutritionally, maybe vitamin D, calcium, magnesium, and other problems. Anatomically, as we talked about, all of these procedures can cause I have to take a note for myself. I think I have the old version of this thing, but so essentially all of the surgical procedures, one way or the other, if they cause any reflux, nausea, or vomiting, or dumping, that will result in nutritional deficiencies, specifically vitamin D, calcium, magnesium, and then as a result, high parathyroid hormone, which starts breaking down the bone, and poor dental hygiene. When it comes to continuing with this, diet and exercise, diet and medication play a significant role into this. And it's also very important to remind ourselves that patients may have pre-existing vitamin D deficiency. 20 years ago, when we started doing this, we were looking very little on vitamin D preoperatively. Many years ago, we started looking at preoperative vitamin D deficiency. And now vitamin D screening is routine part of our workup. And in fact, patients that have low vitamin D levels and we have enough time, lead time between their preoperative visits and the operative time, we will give them the vitamin D injection before we go to the operating room. If not, we make sure we give them vitamin D right after surgery. This is because there is a very high incidence of vitamin D deficiency before surgery, and there's studies that have been published to that effect. Real quickly, vitamin D is essentially processed through different states, skin, and we do a lot of things that result in low vitamin D. We cover ourselves, avoid ultra sort of UV lights with sunscreens, and low cholesterol. Our GI tract, we have even less vitamin D and excessive amount of polyunsaturated fat. This is what chelates and limits the vitamin D absorption. Then our body fat as an overweight patient may result in elimination or removal of all of the available vitamin D for processing. Toxins such as alcohol, smoking, all of which will limit either availability or processing of the vitamin D. Essentially what happens is that the vitamin D is reduced in the bloodstream, resulting either because of the absorption, because of the reduced absorption, reduced availability, reduced processing. The end result of this is I have low vitamin D, low calcium, elevated parathyroid hormone, and that elevated parathyroid hormone will start breaking down my bones, and I have frequent cavities, and no one really is putting this two and two together as to, well, I really can't just keep going to the dentist and get multiple cavities and root canals done unless my vitamin D, my calcium, and my PTH is addressed in the underlying. This is a whole bunch of biochemistry discussion. I think I'll put everyone to sleep if I talk too much about this. But again, sort of the opposite of why is it that the vitamin D is reduced is because all of these steps are not taking place. It's important to remember is that the vitamin D essentially goes through 3 different steps before it's processed. There's the dietary vitamin D3 that's absorbed through the intestine in circulation. It's in a D3 format, goes to the liver, gets processed. First stage goes to the kidney, gets processed, and then that's when it has its functional state of being able to help with the calcium absorption, being able to mobilize calcium into the bones and modulate and help with the regulation of the immune system. Alternatively, if we're not bringing in the vitamin D through dietary means, it's the vitamin D, the pre-vitamin D3, which is converted because of the UVB in our skin, and it's converted to D3, and then the same pathway is followed. Common issues with the vitamin D deficiencies are caused by sunscreen. We already talked about some of these up front. Fat in our diet, saturated fat and trans fat, hydrogenated fat, monounsaturated fats, and polyunsaturated fat. There's sort of the good fat, and the bad fat is, and as we showed it here, the dietary low cholesterol, because everyone is on statin medication, and the excessive polyunsaturated fat are what drive the vitamin D to a lower level. Vitamin D and calcium, a note to our patients, those of you that are scheduled or they're waiting for your vitamin D levels to come in, and you may be expected to get vitamin D injections, please check with our office, call Silva and Christina and talk to them, because vitamin D injections are on back order by the manufacturers. So we actually have no more vitamin D right now in the office, so we're waiting for them to get some shipped to us. But the reference range for the vitamin D, as you know, is between 30 to 100. The old range was between 10 and 30. And very frequently, I will see patients who have a vitamin D level of 10, 15, and 20, and they've been prescribed a vitamin 50,000 IU of 1 caplet a day, once a week. That is grossly inadequate, and in fact, I would even go as far as saying that low dosing will not even do anything. So a patient will need 50 to 100,000 daily of vitamin D350, and or in a form of an injection. I realized that the reference range of this says 100 nanogram per milliliter on the vitamin D level. I have yet to see a patient who's toxic from vitamin D even getting at this very high, what appears to be very high recommended doses. So this is not a typo. We do recommend 100,000 up to 100,000 or sometimes even 200,000 on a daily doses. This is in contrast to taking 50,000 units once a week. Calcium, citrate versus carbonate. There's a whole bunch of stuff on our website. I'm not going to bore you all, everyone. It is important to think about how to take it, how often to take it, with what mixture we take it. It needs to be in divided doses. We can't just take 1,500 or 2,000 or 3,000 milligram of calcium in one form and expect it to get absorbed. With meals or without meals, patients that have kidney stones, they need to take some of their extra calcium with meals to chelate the oxalate to prevent from kidney stone formation. At the same time, if you take all of your calcium with your meals, you may not get absorption as much of it. Excuse me. The vitamin D and calcium do not swing overnight. They do not go up and down on a day-to-day basis. It is important to appreciate that all of these need to be looked at as a long-term commitment. I need to really stick with my vitamin D and calcium long-term enough to make sure it works. Weight loss complications require recognition for them to be treatment. This could be in a form of nutritional deficiency, calcium, PTH, albumin, and protein level. Long-term medications such as bisphosphonates and proton pump inhibitors are also detriment to calcium metabolism. The acid in the stomach may be depressed, and that's what presumptively what's desired because of the proton pump inhibitors. The secondary effect is that significantly diminishes the magnesium and the calcium, and then weeks and months and years later, patients have really poor dental hygiene. Anatomical consideration may be things like strictures and or ulcers. If we are developing early dental problems that we can't just account for, I'm not saying that poor dental hygiene is ever normal, but it is even more abnormal if a 20, 30, 40-year-old individual has multiple cavities and is thinking about bridges and things like that, and we need to think about what could be the underlying reason for that. These are some of the examples. Again, I'm not going to sort of bore all of the details of it, how they can be poor. This is receding gum exposing all of the roots and thinned out enamel. You can sort of see the gross discoloration. And the bottom picture shows how there's cavities in different places. I'm not saying these are all caused by weight loss surgery. These are examples of some of them. Anatomical consideration for patients with the band, the bypass, sleeve, and duodenal switch comes again into a speed bump of some sort, something that blocks the something that prevents from the stuff going through the GI tract, the food going through the GI tract, the stomach content going through the GI tract, and repeatedly comes up in the esophagus, exposing the content of the stomach. So this is an example of an eroded band into the stomach. This patient had persistent nausea and vomiting, the food going down. The angle at which we're looking at, you can see it's essentially an exposed band. An example of a stricture would be a patient that either had the sleeve, and this patient had a narrowing of the stomach. This patient had a hourglass stomach, and that's this is a 12 millimeter balloon. The distance between those those arrows is 12 millimeter. That's about 1.1 centimeters. So you can see that opening where the food was going through is an extremely small opening. So this patient had persistent nausea and vomiting. We had to dilate it, and eventually patient was able to eat and drink afterwards. Other causes may be if there's a stricture or there's a fistula. So this patient had a gastric fistula represented by that blue line there. The problem with this patient was that though the food would go in and we saw the opening of the fistula, food would go in and travel from the pouch from here to there, and then this would act as a reservoir. And at times when the patient's position was so that some of the high acidic content would travel back and it would come up. This patient presented with weight gain and nausea and vomiting, which is sort of counterintuitive. If you're thrown up all the time, why would you have to have, for example, weight gain? With dual switch patients, even though the stomach is removed, at times patients do have reflux. This represents a lining of the mucosa changes between the esophagus to the stomach, and this patient had persistent nausea and vomiting at times early on after weight loss, and that resulted in having a lot of difficulty early on tolerating any significant amount of food or fluid. Again, just sort of talking from a patient's perspective and from a dentist's perspective as to what may or may not be the issue, it's very important that dentists and all of us as patients, as our advocate, think about it that if I have a recurrent problem, I need to poke and probe someone to start looking into other possible causes. Think about anatomy. Do I have a stricture? Do I have an ulcer? Do I have a narrowing of some sort? Do I have a reflux? All of which are causing me to throw up all the time. So that would be sort of the anatomical group of the causes. Or do I have nutrition? I'm not throwing up. I don't have any ulcer. I don't have any reflux. But maybe I'm not absorbing enough of the calcium. Maybe my vitamin D and magnesium is low. Maybe my vitamin K is low. All of which result in metabolic changes that cause my calcium not to get processed. So I will stop there, and I hope I didn't go too fast. Yes, so there is a correlation between osteoporosis and tooth decay. Teeth are one of the are essentially almost all made with calcium and other minerals, and as our bones decay, as our calcium is driven down. So there's a question here that says, is there a correlation between osteoporosis and tooth decay? And that's what I was answering. So if my calcium is down, and because of either I'm not absorbing it or I am not consuming it, and we talked about what will drive calcium down, too much sunscreens, too much stand medication, obesity, poor diet, alcohol, carbonated drink, and so forth. So if my calcium is down in my bloodstream, in my serum, regardless of the cause, that will result my internal built-in mechanism to kick in, and that will cause my parathyroid hormone to go up. The parathyroid hormone's objective is to normalize my calcium level, and one of the major mechanisms by which it normalizes my calcium level, it sends a signal to the bones to start breaking down the bones. Teeth being considered a reservoir for the calcium in that mechanism, eventually will start breaking down in order to maintain a normal calcium level. So yes, the osteoporosis can manifest itself, amongst other things, as tooth decay. Now, the problem is that I don't know if there is a way to distinguish between a tooth decay caused by poor dietary issues, poor oral hygiene, high sugar consumption, things that will render themselves or cause them to have this, or osteoporosis, but they do go hand in hand. Any other questions? The relationship between bisphosphonates and calcium and parathyroid hormone. So bisphosphonates is bisphosphonate is a class of medications that is supposed to it's not supposed to, but it does. It is designed to improve the osteoporosis, and in fact, it favors the bone building mechanisms built into our normal physiology. So we have cells in our bones that break down the bone on a daily basis, and we have cells that produce bone on a daily basis. And the concept is that we take old bones down, we make new bones to help make healthy bones all the time. As I become old and friable, or I have conditions that make my bones friable, what happens is the bisphosphonates are supposed to help with the cells that are making more bone cells, so they move the calcium into the bones. The problem with the bisphosphonates is that, unfortunately, if a patient who's recommended to take the bisphosphonate has not been checked to have adequate amount of vitamin D and calcium, this is not only not going to solve the problem, but the long term it may actually make it worse. I believe in this concept so firmly as much as I would recommend to patients, and I've heard this from other endocrinologists too, that they would not start a patient on a bisphosphonate class of medication unless they have had a normal calcium and a normal high to mid normal level of vitamin D for a 3 to 6 months period. So a patient that starts with a low vitamin D level should push their vitamin D by oral or IV or injectable vitamin D supplements to mid 40s, 50s, 60s, 70s, and 80s range, and maintain them in 3 months, 6 months, 9 months. Only after that, one should consider going on bisphosphonate medication. Just normalizing your calcium level and vitamin D level for a week or so doesn't really change the underlying physiology that's going on with the parathyroid hormone. So normal calcium, normal vitamin D, maintain them long term, then think about bisphosphonate medication. So how much calcium, maximum amount of calcium a patient can take per day? I'm not quite sure what you mean by usable. I think the best way to, what we clearly know is that is you really want to take about 500-600 milligrams of calcium in divided doses. You want to avoid taking calcium with other minerals per se, because think of it as they're the same receptors or same group of receptors that are trying to get these minerals down. So if I take a whole bunch of calcium and magnesium and iron and other stuff together, zinc and copper, they're all probably trying to get through the same door, and not work. So 500-600 milligram in divided doses, take about 2 or 3 or 4 hours apart with each other. And more importantly than how much do I take is my blood work long term. If I'm taking a certain amount and my calcium, vitamin D, and parathyroid hormone is stable, then I'm good to go. If I'm taking what I think is maximum amount and I've been seeing my calcium trend downward, then what I'm doing is not being absorbed. Now I need to either think about taking higher doses, different formulary, different time, or a combination on all of them. That's assuming my vitamin D, for example, is normal. That's assuming, for example, my magnesium or vitamin K level is normal. Any other questions? Well, if there's no questions, I would like to thank everyone for joining us. And I'll leave the chat open for a few minutes. If you have any questions, let me know. If not, see you all next month. And you have a nice rest of the week and the weekend.